ONtheGo podcast. Cartilage Insights of the Ankle in 2040. Future Endeavors and Insights by Professor Gino Kerkhoffs, Chair Department of Orthopedic Surgery of the Amsterdam University Medical Centers, and Dr. Jari Dahmen, Amsterdam University Medical Centers, University of Amsterdam. My name is Taka Oshima, and this is ONtheGo, the podcast all around orthoregeneration.
Okay, so we're here, the ONtheGo podcast with Professor Gino Kerkhoffs, Cartilage Injuries of the Ankle in 2040, Future Endeavors and Insights. And as our listeners know, we always start with the same question to our guest of today, and that is, how do you drink your coffee? How often? Where? And what are your favorite places? Welcome to the studio.
Thank you very much, Jari. It's a great honor to be here, to be able to talk on this great subject. The coffee. So we just had a very nice double espresso in the hospital. Drink it from a paper cup. Sometimes from our own cup. We drink it from home. And my favorite place to drink a double espresso would be in Sardinia, beautiful island in the Mediterranean.
Mm-hmm. And last time you mentioned it was ristretto.
Ristretto is the best, It's I like best, and then straight without sugar. Unlike the Italians who think that sugar should be added, but I tried it. I like it straight better.
Yeah. So that's great to hear. Then just because it's almost the holidays, but just going a bit back into the hospital and related to that coffee, what will be your favorite place there and your best place to just get some inspiration with your coffee, or your go-to place?
Go-to place is normally, to be in the surroundings with your youngsters, either be at the table tennis or somewhere in the department where I can find you. We're quite closely to going outside with the students, as we are situated currently waiting for the departments to be refurbished. So I think, the place that we're housed at the moment, all together with the young research team and the residents, that is where I like to be most. So that's the safest place in the hospital that gets me most inspiration. And other than that, the outpatient clinic and the ward and OR, obviously, are also great places, but the best place is with the young researchers.
Mm-hmm. So that's just surrounded by your team to get some inspiration. Somewhere else that you just when you need to be alone or to get some downtime to think about things inside the hospital to take your coffee with, what is your place? Do you go for a walk outside, or?
I think walk outside is one of the best kept secrets. Yes, I think quite some years ago when I was appointed a full professorship, they asked me this question. So, how do you get your mind clear? And then I also answered, get some fresh oxygen in. And sometimes we do our research meeting outside. We even discussed to do this outside, but because of the microphone and the wind in the Netherlands at the moment, we decided to be inside. But I like to be outside to get some fresh air and get some positive energy out from nature. So I like that. And then the hospital also on the AMC side of the Amsterdam UMC. A little bit more than on the Boelelaan. We have lots of artwork. So just walking through the corridors and having my own art route if it's off time in the hospital. So before 7 or after 7, then that's also very inspiring.
Yeah.
Not too many people around.
Yeah. Okay. Well, that's great to hear. Then we know at least outside of the hospital and inside of the hospital where not to find you from our side. Going on to the subject of today, we're talking about the future endeavors of the cartilage injuries of the ankle in 2040. So in a couple of years already, if time's going to fly in that sense. As an expert in the field on this subject, could you give the listeners and us some insights or an update on where we currently are with the cartilage injuries of the ankle?
Thank you. I think I suppose where we came from is doing some casting or a debridement and drilling for everything. So I think together with our team, as being the Amsterdam ankle cartilage team, we kind of developed a lot, I would say. So we have we tried to have a good solution for every stage of the cartilage damage in the ankle. I think the early stages are still most promising, but also most hard to get a good result already. So what we currently have, I would say, is for symptomatic cartilage lesions, being partial surface or full surface cartilage lesions, osteochondral lesions, or early stages or later stages of osteoarthritis. We'll try to have a solution for everything. We have a flow diagram. We look first at alignment. We look at instability of the ankle joint. We look at factors, personal factors like BMI. We look at the expectation management. We look at the mental state of people. And then we go down towards the ankle joint. And then we'll have the debridement and drilling for the smaller lesions. We'll have the retrograde drilling. We'll have the lift, drill, fill, fix. We'll have the topic procedure. Both techniques that we developed, as you well know, because of all the publications on this and the recent publications. And I think if we look at the overseas procedure, the OATS, especially the group of John Kennedy at NYU, have really developed further, published good results. And then we have an open field of regenerative medicine procedures, both secondary preventive injections as well as cartilage procedures that still have to prove their exceptional benefit at the moment, I would say, because I feel that there's no comparative series yet to prove what's all out there. But I think that is currently the field, ending in either metal, like in the other joints, and meaning a total joint replacement, or in a fusion.
Yeah.
So that is, I would say, currently the field, with some additional treatments I didn't mention, but I think this is the big line.
Yeah.
So I think what we came up the last 10 years is that we managed to have better treatment options for big osteochondral lesions that are fixable. So if you can fix it, fix it. And then also bigger lesions where currently allografts or metal part procedures was used. We now came up with the topic, and that seems also most promising, at least a 2-year, and in a small look through at 5 years from part of a series, it looks at will stand the test of time, like the LDFF did. So I think that is where we currently are.
Yeah. So I think we'll touch a bit more upon the regenerative injection therapy and the topic and the LDFF also a bit later. Through the story that you're telling, we can also hear the lines of research and the lines of current knowledge on the symptomatic phase. Could you tell a bit more about the thought of the asymptomatic preclinical phase and the symptomatic phase later on, and then the OA phase? So a bit more on the cartilage cascade.
I think, so cartilage cascade we published together means that as we've been knowing for decades that ankle OA is in 90%, 95% post-traumatic, and that is a concept that is well embraced. We thought, okay, so where does it start? So probably certain percentages of every simple but not so simple ankle sprain, every fracture, every syndesmotic ligamentous injury starts this cascade. So we know from basic studies that we published in Cartilage together with Theo Smit and Robin Blom that even a single load impact changes the quality of the cartilage. Not noticeable on micro CT scan, but on cellular level, you can see that indeed there's a catabolic state in the joint, and that the quality of the cartilage is much less than before the impact.
Yeah.
So then we know that the cascade is started, the joint gets into a catabolic state. There's more inflammatory response than necessary to give a good content to the cartilage. And in a certain percent of patients, this will really initiate the whole cartilage cascade, as in deterioration of the joint over the years, ending all the way from non-symptomatic phase, then cutting the line into a symptomatic phase with early OA or OCDs, and then ending up in the later stages of OA with metal prosthesis or the fusion as the main treatments there. So I think interesting would be to know which patients are really heading for the OA and which patients are able to restore the anabolic state of the joint by themselves and do not deteriorate over years.
Yeah.
So that's, I think, one of our challenges that we can face together. I hope at least by the end of your career, you will have the answer. But I hope that I can be part of that. But I would say that is one of the big challenges, to come up also with a primary preventive intervention in the early stages, for example, and people with a high BMI that still want to be active, but make high impact loading with every step on the joint, or in top athletes that have lots of pivoting sports and a lot of impact there, and might be willing to be back on the pitch after a sprain trauma within 7 days, as we know that the catabolic state will have not been restored into an anabolic state yet, so might be damaging even more in these stages, but they will still want to be on the pitch. So I think that's an interesting challenge to come up with new stuff.
So that brings us some more knowledge on the cartilage cascade and also the places of challenging endeavors on where we should focus on. Maybe already related to that is going into the implant that you and your team have been developing. Could you tell us a bit more about that project and where in the cartilage cascade it fits in and where it potentially would lead to in the next coming years?
Cool. Thank you. Yeah, I think together with Theo Smit, Tobias Stornenbrink, and the rest of the cartilage team, because of kind of endeavors and everything, as well as Tony Bosman, we came up with this thought on that probably the cascade starts purely as a biomechanical issue where the load changes joint homeostasis and gets a joint into a catabolic state where there's leakage of water, the gag content of the cartilage changes and the deterioration starts, but it's also able to restore. And whilst lots of the cellular therapies currently try to restore this one by one at the cellular level, we thought that restoring mechanical environment and partially offloading the joint with slight distraction, we combine the biomechanical aspect that we know will restore the catabolic state into an anabolic state. From different research where you see partial offloading is able to restore cartilage quality, as well as slight distraction of the joint has the same effect. So if you combine that by injecting an implant that cushions the joint and partially offloads, as well as slightly distracts, that will then be the high road to restoring the catabolic state into an anabolic state of the joint, and both preventing enhancement of early cartilage damage into gross cartilage damage, as well as potentially being a treatment for the early osteoarthritis stages, or maybe a severage stage for the later stages of osteoarthritis. I think to get into the market, we will say, okay, this injectable implant is able to restore alignment of the joint. And from there, we will see which steps we will make with that. Currently, we're in the later stages and we'll hope to get into human trials within the next 2 years.
So that
so very promising and interesting road to travel together.
Yeah. So that's also, I think, when we're talking about, because we already brainstormed a bit on where will the patient be with cartilage injuries in 2040, and where will the orthopedic surgeon or the clinician be in 2040, and the researcher. That injectable implant would lead to that year. Related to that, I think, is also a question that came up earlier is, do you think that in 2040 we will, for example, combine the injectable implant with some, for example, patient individualized components of the injectable implant in order to really lead into the genetic predisposition?
Yeah, very interesting. I think because that is another aspect. So it's a very interesting question. Yes, I do think, for the major example of non-weight bearing joints like a CMC joint or the ankle joint bearing most load, there will be different types of injectable implants. One having better providing better protection to shear forces, one better to axial loading forces, and that will be probably the road to go. And I philosophize that people will look in the watch and say, oh, well, my right ankle joint needs some more cushioning because I did some damage there. It's slightly inflamed, so better get an injection. Or I will see medicine making a huge shift from being a treatment to going into a prevention of the onset of diseases. As we know that the OA is a major disease and provides an enormous burden to the world. I think it will be very good if we, as a group, also with thanks to the ON Foundation, we are a group, work on this road towards the preventive treatments and not so much on the end stages, because it will be an easier place and provide better motions for all the joints and stuff, and happier patients.
And now we're still really looking at that first phase and focusing on that first phase. Later on, we'll also talk a little bit on the later phases in the cascade. Just zooming a bit more onto the first phase. Could you share some insights in, for example, there's still a couple of decades left till 2040 with regards to that implant or with regards to that primary preventive option. What specific research types would you do and research projects would you do with the team included if you would have unlimited resources? What would you put on the table to really get the answers resolved, the questions resolved?
Yeah, I think there's a veterinary world that will benefit from this because we know that from our pets like dogs, they suffer a lot from osteoarthritis as well. Wanting to bring in implant to the market and available for the humans, you will have to make some proof of safety and also of treatment effect in the animals. So I think they will benefit a lot. We already know from our studies that we've conducted so far that it's going to be safe. So building up this dossier in order to go to the market, that will be a major thing. And then the most helpful for us would be considering that we will have the knowledge. I think also we'll have a very credible group of researchers throughout Europe and the world to help us come up with good human trials. The thing that we need most is help to get the product to the market, as we don't have a lot of experience there. So I think if we would have unlimited access, then I would have some very smart directors who've brought good and promising products to the market in a safe way, in order to allow us to bring this to the patients quicker. Because that's a good aspect that, working in the academy and university, we have lots of resources, very good people surrounding us. For the youngsters coming up with smart ideas, we have some experience as well. We have a good network. But for the business side of things, in order to get there, I think we'll need some extra help there.
Yeah,
that would be most beneficial.
Okay. That already gives us some inspiration to in order to get the project even more successful than it is now, from the practical side of the view. Going a bit more into you could maybe call it the second phase of the clinical phase of the cartilage injuries, just before the OA, are two techniques that I think would be good to highlight that have been developed in the Amsterdam UMC. Maybe you could give us some more insights into the indication and outcomes of the LDFF and the topic technique, so that our orthoregeneration listeners will have some more knowledge on that as well.
That'll be good. So the lift, roll, fill, fix procedure, or lift, fill procedure, as it is called in the United States, originates basically from basic traumatology. So it's non-unions are treated by debridement, refreshing of the old fracture sites on both sides, adding some biology, having good alignment, and then great compression and stability. So if you would look at a desiccate of an osteochondritis dissecans that's been traumatized, it's now a little bit loose, you could look upon this as an interarticular non-union. So the lift will allow to debride on both sides, so both on the desiccate side as well as on the talar side, for example. Then the cancellous bone from the distal tibia, after taking away the distal tibial rim, arthroscopically or open, will allow for some extra biology. And then the closing, you see if you have the right height of stuff, and then you can fix with 2 screws to have a rotational, stable, good compression. So that, in fact, the LDFF is an interarticular non-union therapy that we are able to conduct arthroscopically if the defect is fairly to the anterior side of the ankle joint on the talar dome, because we do want the screws to be perpendicular and basic, and then slightly divergent to have rotational stability as well. We could also do it open on the medial side with an osteotomy. So then you have open access, and on the lateral side with either a lateral ligament release or a combined lateral ligament release and an intimate distractor, or even a fibular osteotomy. So different aspects there. I think it will allow to maintain hyaline cartilage. We've seen that there's better subchondral healing after an LDFF procedure compared to debridement and drilling. And we've seen that it stands the test of time. So about 90% good results, as in good function and much less pain at 7 years follow-up, as we published together, and was Quintin who was the leading author there. So I think that's LDFF.
Yeah.
And then the transosseous periostic iliac crest graft for big lesions, I would say on the talar side, but maybe also on calcaneus side for subtalar lesions, as well as on the tibial side. A good technique that comprises of a press fit graft that we take from the iliac crest, has all to do with providing good stability, providing the cells, and having the cambium layer, sorry, didn't get the name, as being the best precursor cell line that we can provide. So we'll have everything there. It allows us to take out the disease part of the talus, debride the rest, get the biology from the other sides of the talus, and then put in the graft. We see a full 100% union line of the graft that we put in. As you know, well, you published the results yourself in the GPGS just a few weeks ago on our 2-year results. It's very promising, as we know from the knee, that it's been tried before and that they see deterioration after year 5 to 7. We don't expect that from our preliminary view in our cohort, but I think it's also very promising. It's you get access through an osteotomy or to an anterior approach of the ankle joint, as we know from the TAR, or a lateral approach, as has been described before for the LDFF as well. So it's an open procedure, and we do think that everything before very end stage osteoarthritis is a very good patient population to try this on. The younger, the better. So if you have a youngster that is really hampering in life because every step is painful, then do not hesitate to put this in once the growth plates are closed.
Yeah,
I think it's a very good procedure, especially in the youngsters. We've seen incredible results with return to performance in sports where you wouldn't have expected that before with other techniques. So cheap, that's the only downside, I would say. That's for industry-wise, it's a little bit less interesting, but patient-wise and for doctor-wise, it's a good technique.
So that gives us more insight into the secondary stage. Just bringing those two together and maybe even looking beyond 2040, maybe even 2060. First question is, do you think that we will have at least some osteochondral lesions in 2060? And second one, how personalized or how individualized, and even more in comparison to now, will the treatment of those osteochondral lesions be in the future? Will we, for example, put in a very sophisticated AI model or a genetic model? What are your thoughts on those two questions?
Good. I think with the knowledge that I'll start with the last question. I think the use of AI will be very helpful. Will also be quite easy with all the knowledge that we've gathered the last 7 years, and will gather the upcoming 10 years. We have the right to survive the upcoming storms, but I expect us to be happy in the same field as well. And then I will think will translate our knowledge easily into the AI programs that will provide this knowledge for the rest of the world, because it's not that difficult. I think we've peeled off this onion quite well already, and then come up with options for the patient where different patient aspects at different moments in time can also be considered. The way I would almost say the way we're currently performing our practice would be well translated into an AI program that can be filled in everywhere. Then if you put on the single osteochondritis dissecans, we know that partly they're there genetically. So unless we will go a very harsh way and then have genetic manipulation everywhere, which I wouldn't like, but then I expect these lesions still to be there. With patients being active, they will also traumatize them and loosen them a little bit in their fiber attachment, and then this problem will still be there. So some fixable, some repairable or replaceable within a topic procedure, and some will be prevented. Because the purely traumatic ones will benefit from primary preventive interventions, like the injectable implant, for example. So I think it will not have a different pathway, but will continue on this pathway. And then it's even more highly individualized towards 2060, with less people ending up in end-stage osteoarthritis. Still room for operative orthopedic surgery, because we have a lot of people with a replacement like myself that will need a revision at a certain point in time because of all the longer life expectancy and people are more active. So there's room for both, I would say.
So hopefully in 2040 or 2060, we will only have the fragmentous osteochondritis dissecans left, and all the other ones have been prevented well in an early stage.
That would be great, yes.
That would be our goal for the future. Okay, I think that's a good one to finish off the content part on the cartilage ones. I think last few questions on the orthoregeneration part behind the research. Just a few questions. We just touched upon it in the beginning as well. on where you get your inspiration from with, for example, the coffee, but now a bit more on a general side of view. You seem to keep innovating in the different stages of the research for the cartilage projects, but also outside. How do you keep innovative over the years, and where do you get the inspiration from to come up with new relevant research questions? How do you do that?
I would say this is a well-kept secret that I don't do it myself, but I get it from you as the youngsters. So I get inspired by active, intelligent, sporty, nice young people, and I think we took up the challenge to give everybody a home, so feel in place with all the sporty activities and all the stuff, and I think that is probably the secret. For example, our early Friday morning meetings that you've been chairing for years now. Julian's currently co-chairing, and that's every 2 weeks that we sit there between 6 and 7 in the morning, and friends from all over the world who are interested in our topics tune in, and then every Friday we have new thoughts and new ideas, and that's, I think, how we try to continue to develop. I think that is one of the secrets. I think should not be afraid to get new ideas by people who have different approach, because they're not so experienced yet, but are well equipped to think, and to have new thoughts. So that is fantastic. So that is and that is also the secret, I think.
Yeah. So if you could really translate into then an advice or tip is make people feel at home, generate a home, and organize a bi-weekly or a monthly meeting.
I would think so, and I would say for the elderly or the older ones, I would say get inspired by the youth, and for the youngsters, I would say if you join the team and get a place in the first 11, and then score your goals or be great in defense, and do what you're good at, and try to develop yourself. Look at different positions, maybe different teams, and go out and get it, because you can do it. And we have a great profession as being sports related orthopedic surgeons or sports medicine physicians, because mostly people come to us with a problem in their motion, so they can't move, or the walking is painful, and once you've had that yourself, you know how distressing that is and disturbing in life. How nice it is if you're a doctor who is able to help nature a little bit and help the patients to get back on their feet and have a happy life, being in motion without too much pain. So I think it's great that we still have a profession that is able to provide results within due course, and will also be great if we help to prevent even these injuries from occurring, or the cascade from going further. So it's in any way it's great to be an orthopedic surgeon or a sports medicine physician working on these subjects.
Yeah. All right, that's great to hear. I think enough inspiration for the ones who want to start a team then in the OrthoRegeneration network. So then we're almost close to closing the podcast, but as you know, before we end the podcast with also some personal questions, just how we started the podcast. Don't worry, these won't be about coffee, but these will be a bit more personal. The first one is always the trickiest one, but what can be considered your guilty pleasure? What do you consider your guilty pleasure?
So the viewers should know that we've done this podcast before.
Yeah, so you have time to think about it.
But it's still not there, So I don't think that I have many things that are not already out there, as in that they're not known of. But I like to drive around in the Bullet. That's one of the things, and I like my beers with the team. Family is always first that I like best, and then once I'm working, I like to go for 220%, and that's about it. And the rest is better to discuss in the real bar.
we have the background here, but people can ask you the real guilty pleasures in the real bar.
That's it.
Then the second one that we also discussed before, what is typically something that people don't know about you?
Oh yeah, I think maybe they don't know most of the time that I was born as the one child of my parents, Jan and me, and that I originate from Maastricht, so from the south, and not from Amsterdam, like my wife does or you do, So I think these are just little aspects that I think of that they probably mostly don't know, because they recognize me as being from Amsterdam. Considering that I also support Ajax, it kind of fits. And didn't forget that I played at Maastricht, but I think a little bit like that.
Yeah, that would be something. All right, and we discussed another question before, but I won't ask that one because I need to put you a little bit on the spot here. But if you wouldn't have become a clinician / researcher / professor, what other profession would you have chosen?
Interesting, like many young people, I should now say, because it's female, both male. It seems to me that I would have liked to be a football player, like a real player, a little bit better level than I reached myself. that would be good. And then I think an artist, as in like a painter or a poet, I would really like that. I think I have more talent to write poems than really to draw. But I think I would have liked to be that, yeah. But there's also still time to get to that. So I would say an artist, and then either a writer or a painter.
Yeah, great. And then just to finish it off in the last question, what will be your top 3 advice for an upcoming clinician or researcher that is maybe also outside, but mostly related to the orthoregeneration field?
Okay. So listen to the patients very carefully, stay very motivated, and stay fit yourself. Take care of your partner, your family, and then give 200% whilst you're at work. Like I've got about 4 or 5 sisters. Okay.
Perfect. We'll listen to those advices and then combine it with your advice on how to start or consolidate the team. And then I think everyone will be successful in this field.
Nice.
Thank you very much for your insights. And we wish to welcome you to our next podcast after the summer.
Cool.
Thank
Cheers.
you.
Thank you for working together. Great. Cheers.
Awesome.
Stay motivated and fit as advice from Gino Kerkhoffs, and stay tuned as advice from us. For more content at my.on-foundation.org. Thank you for listening and have a great day.